So, introducing the Diadem Diagnosing Advanced Dementia Mandate for Care Homes webinar. What we're going to cover in this webinar around Diadem is firstly the background of the tool and when it should be used. What I see is a presentation of the later stages of dementia, why a diagnosis of dementia is important, dying and dementia, consent, how to use the tool, the pathways following diagnosis, and the plan for this service evaluation of Diadem. What is Diadem? Diadem is a tool for diagnosing advanced dementia in people who live in care homes. Take-home points are that 70 to 80% of care home residents will have dementia. This tool supports primary care clinicians to make a diagnosis without referring to memory clinics and having people attend formal clinics, and it increases the likelihood of people receiving good post-diagnostic care. This tool is designed for people with obvious moderate to severe dementia. It is not designed to look for borderline dementia, early stages, and it is not designed to deal with complex cases. So it's almost a verification for those people that you are pretty certain have an advanced dementia to help you make that actual diagnosis. What I thought it might be helpful to do is paint a little bit of a picture of the type of person and the presentations you would see of somebody with the later stages of dementia, so you can understand the type of person I would expect you to use the tool with. If you want more information, there is a link on this slide that takes you through to the Alzheimer's Society website, which gives you fairly easy to read version of what the symptoms and signs are of later stages of dementia. If we look at the later stages of dementia, you will see a picture of somebody who's becoming increasingly frail and who's more dependent on the other people around them for support. As the dementia progresses, you will find that they get changes in the person's brain and they will struggle to do more things than they used to be able to do. They may have times when they're better than others, but these returns are often quite temporary, but people will fluctuate a bit. The person's reactions to their environment will depend on how they'll feel. So sometimes you will find that things are more positive when environments are familiar and comfortable, but maybe more negative if people have problems in their environment or issues such as pain. I'm going to cover just a few areas, but this is not just about memory of the kind of picture you would see with somebody in the later stages of dementia. I'm going to look at memory, concentration, communication, mobility, eating and weight loss, toileting problems, and changes in behaviour. So remember, this is all about a picture of that person that you're going to see where we think the use of this tool would be beneficial. Memory in the later stages of dementia. As time goes on with somebody with dementia, you'll find that their memories from the past may stay, but the more recent memories are lost. So actually they'll forget the day-to-day things. And because of that, they may think they're living in an earlier time period of their lives. And so that means that they'll find it more confusing to make sense of the here and now. So, for example, people thinking that a partner may be a father or a mother rather than being a sister or a child. And they may then go back to some of those emotions that they had from the past. And some of those could be positive, but some of them might actually be quite distressing. So, for instance, if they go back to times when their children were at school and they're worrying about collecting their children and they can't, then that might come out as distress. They also may have difficulty recognising themselves and their people around them as who they are now, and that can be quite distressing for families and for the person living with dementia themselves. They also may have difficulty associating the place they're with, but they may have emotions that are good or bad, depending on where they think they are. So if they feel comfortable and the place is familiar, even though they may not recognise that relative as being their husband, they feel comfortable with them, so they will be happy, so they can still feel positive emotions even if they can't remember all the detail. Around concentration and planning and organisation, these abilities go, so they may find it more difficult to carry out sort of very simple tasks, or they may find that they can't concentrate for very long. So that might mean they become disorientated and may forget where they are, and understanding of time. So you'll find that very simple activities, such as maybe, let's say, dealing, they wouldn't in a care home, but dealing with money, or the sequencing of getting washed and dressed and organising what they're going to wear may go. Around mobility, dementia can have a huge physical impact on somebody in the later stages, so they may gradually lose their ability to walk or stand or to get themselves up and out of a chair, and they're more likely to fall. That's not all due to dementia. That is going to be compounded by other medical conditions, medication, sight loss, balance problems, but you will see that falls are more likely to happen and mobility is more likely to go down in somebody in the later stages. People also find that they end up sitting or lying for long lengths of periods, so they don't move around as much, so they're at greater risk of pressure ulcers. So again, this picture of a frail older person who is having issues around getting around the care home. With communication in the later stages, often they're less likely to have respond verbally to questions. They may have more limited or no speech. They may repeat phrases or single words, or the words they say don't make sense. And sometimes people, instead of communicating verbally, will resort to facial expressions, gestures, sounds as their way of communicating how they're feeling. So some of it will be about understanding how they're communicating and what it means, but you will find that this general picture of somebody being less able to articulate to you as you in the later stages of dementia. Eating and weight loss in the later stages. Weight loss, eating becomes, people forget, people can have swallowing problems, this may result in weight loss, which means they're more likely to have difficulty fighting infections and more at risk of pressure ulcers and loss of muscle. And swallowing problems can lead to things like aspiration pneumonia and being unable to eat certain foods of certain consistency. So again, you're seeing this picture of somebody along with the others that fit with advanced dementia. Toileting problems, it's a group of things that happen to somebody in the later stages of dementia. You don't have to be fecal and urinary incontinent, but it is more likely to happen. And they will have problems because they may drink less, so they get more infections, problems with constipation, being unable to tell you that they're having problems with constipation, side effects from medication, but also forgetting to go to the toilet or where the toilet is, and not recognising their own personal need to go to the toilet until it's too late. All of these lead to an increased likelihood of incontinence. And finally, there are behaviours that are more likely to happen in the later stages, such as distress and agitation, confusion about where they are, sundowning, where somebody becomes more agitated in the late afternoon and early evening, which can be all about not knowing time and place, too much or too little sleep, medication, alterations of the body clock, which means that people are more likely to distressed behaviours later in the day. And then sometimes people can become aggressive. And this may be because they feel threatened or frightened, and they don't know what people are doing to them, so their only way of dealing with that is to try and protect themselves. So seeing it as a protection rather than deliberately trying to hurt somebody. So if you put all of these things together, that's the kind of picture of the person that we think would benefit from having a formal diagnosis where they don't. There are 2 rating scales which can be found on System 1, and we'll talk at the end about how there may be some changes that we need to make so that district nurses can have access to some of these tools so that they can see this. And you'll see that this is this picture of moderate to severe dementia that I have just painted that's clear in these two rating tools. One is the clinical dementia rating tool, and the second one is the global deterioration scale. And what we're not trying to do is find people at the beginning of their journey through the life of dementia. So how did we develop Diadem? Diadem was developed by following two existing tools by two older age psychiatrists, where they wanted to empower local GPs to make a diagnosis without resorting to somebody having to come to tick a box in the memory assessment clinic. And we used feedback from those two existing tools, and then we merged it into a new single tool, which was then reformatted and shared again. And it's changed over the last few years. At the beginning, it started off with the 6-bit tool, and mostly used in, which was a tool that was mostly used by GPs in Yorkshire and Humber. We've now got a GP cog version for some GPs from the south, and the newest version, which you're going to be using as district nurses, is the mini cog. And all of this is about some flexibility around that. We've also added in more about consent, and the tool has grown as the years have gone on. But it's been generally accepted by everybody, both old age psychiatrists, GPs and primary care, that actually it's in the best interest of the person living with dementia to get a diagnosis, and this tool helps them to do that. Why did we choose care homes? What we know from the evidence is that care home residents, 70 to 80% of them are likely to have a dementia, but then many of them don't have a formal diagnosis. People who live in a care home have already passed the threshold for that means that they require care, so they're more likely to have a more severe dementia. And at the moment, we know that many of them are denied a diagnosis because they're unable to get to a memory clinic. And also because people don't see that there's a benefit for care home residents, and we'll talk about what we think the benefits are in a moment. There was a paper came out by CQC called Cracks in the Pathway that actually said that actually if dementia is diagnosed in a care home setting, there were some great examples of good care that could be delivered if the diagnosis was known, but that there is a significant variability around the country where people aren't known to have dementia. What we think the benefits are, and it's really important that you think about these because this is the sell to the care home and the family when you're going to use Diadem to make the diagnosis. I see it as a gateway to better care. It helps, for me, especially I've noticed that it really helps an understanding between relationships between the person living with dementia and the person and the people caring for them, whether that's professional carers or family and friends, understanding why some of the behaviours happen, but also recognising that even if somebody doesn't recognise you, the fact that your presence makes them feel content may help families to go on visiting when they may have stopped before. I think it also enables the person living with dementia and the care homes to get support with care planning and treatment. It helps the flow of information, especially, say, during transitions of care. So if somebody ends up going into hospital, actually having that formal diagnosis means that people are more likely to understand and put plans in place to help that person during that stay, and maybe think about things like prevention of delirium. And also it helps care home staff think about, okay, how do we prevent delirium? How do we use care home liaison? And how do we help them to understand when people are distressed and how they might manage those behaviours? It also gets staff to think about the rights of somebody living with dementia and to things like the Mental Capacity Act. It also allows families and people to think, and their carers to think about what they all might want for future wishes and around care. Too often we see people admitted to die in hospital because people hadn't recognised that they were dying, or hadn't asked that question about what do people want around those last weeks of life, and enables a good death to happen, and a dignified death, rather than what often happens, which is dying within a few days in a hospital they don't want to be in. I've just put on here a page because I think it's important that if you do diagnose somebody with dementia, that you do think about advanced care planning. And we'll talk a little bit more about this at the end, but this is the advanced care planning document that is available for everybody in Bradford, whether you have dementia, a cancer, or dying of a long-term condition such as heart failure or COPD. It's the same advanced care plan, and it's used across all settings, and people living with dementia have as much right as anybody else and their families, and in those care homes, to start planning for a good death. Very importantly as well, that families and professional carers may want to think about advanced decisions to refuse treatment. Remember, in this situation, we're talking about people with advanced dementia, so they're unlikely to be able to have much insight themselves, so this is more about a best interest discussion. But again, it's about trying to plan ahead and think about what's in the best interest of somebody, especially if they've had a recent admission into hospital. Just thought I'd put this in because this is one of the reasons that people often die in hospital. If you look at three very typical scenarios of people who are palliative, you'll see on the top one that cancer, people are sort of pretty much okay, and then they take this massive downward slide into towards death and have massive weight loss. And so we sort of understand that, and we see cancer death, and we sort of understand when somebody's in the dying phase. And that's sort of easier to understand. The second one down is organ failure, so this is sort of heart failure and COPD. And there we see that people are declining, but have massive dips when they're unwell and end up in hospital often, and then sort of rally and come back and then have other dips. Again, a bit harder than the cancer one to anticipate when the final big dip will happen, but once somebody's had a few dips, people start to think, okay, it is the last year of life approaching. And you'll see on the bottom one that this picture of frailty and dementia, which is more, as I talk to families, around grumbling along the bottom, really. And that's much harder to see that death might be about to happen in the next year. So I think diagnosing dementia gets you to think, actually, when you make that diagnosis of advanced dementia, is this somebody who is in the last year of life? And I think I put on my next slide just a few details about dying and why it's important. So there are three ways that people die with dementia. They either die from complications from end-stage dementia, let's say maybe an aspiration pneumonia. They may have dementia but die from another illness, such as cancer, so they may be in the early stages. Or they may die with a mixture of problems, but dementia isn't the main cause, but complicates it. And that's one of the very common ones. So people may be dying following a fracture emphysema, where dementia has complicated their care. How do we know when people are in the last year of life? Well, this is quite difficult for dementia. There was a study of nursing home deaths that found that people with dementia were likely to be given a prognosis of more than 6 months, but actually 71% of these people died within that 6-month period. So we know we're not very good at it. And that goes back to this grumbling along the bottom picture. We're not quite sure when it's going to happen. DSS have developed some prognostic indicators that suggest that somebody is in the later stages. And some of this goes back, if you think about what we said about Diadem, the people living with that advanced dementia, some of these may be some of the similar indicators. So it might be quite important, if you do make a diagnosis of dementia, to think, actually, is this person in the final years of life? Do we need to think about the GSF? So the suggestions are that somebody is unable to walk without assistance, They're both urinary and fecal incontinent, they can't have any meaningful conversation, and they're unable to do any of the activities of daily living. And I put a Bartel less than 3. Sandra has told me that you don't use Bartel much in district nurse land, but actually it's just a measure of activities of daily living. So a score of less than 3 means they're virtually not doing much for themselves. And then what we say, as well as that picture of extreme frailty, people also have weight loss, recurrent infection, urine infections, severe pressure ulcers. You don't have to have all of them, it can be any of these. Recurrent fevers, not eating and drinking, or aspiration pneumonia. And all of this points to the last years of life. Another question I've asked, which I thought I'd show you a little picture, is how do I know as a district nurse that somebody has dementia? So when I'm thinking about using the Diadem tool, how do I know that they're not already on the list? So I've just I've put a screenshot here of Minnie Mouse, one of our test patients on System 1, and you'll see when you go on System 1 that you have a set of icons below the name. And what you'll see with dementia is a head icon. And that means that they're already on their GP register with dementia, so you don't need to make another diagnosis. And in fact, I'd hope that you'd already know that they had dementia. So that's how you know somebody's already on the register. So moving on to a bit more about Diadem, and then I'll show you how to use it. Question that we get asked quite a bit, probably more by GPs who get very worried about making a diagnosis of dementia without going through formal memory assessment services, and they're worried that they're not fulfilling nice guidance. So what we're saying here is that a referral to memory services is, in this, somebody with advanced dementia is rarely going to be desirable because it's going to be distressing for them, and it's usually unnecessary. This is backed up by some guidance for commissioners of dementia services. It's also supported by our National Clinical Director for Older People's Mental Health, Professor Alistair Burns, and he wrote this out in a letter to GPs in 2016 when he recommended Diadem and the Dear GP tool to help GPs. So I think we're fully covered as a mandate for using this tool, and we don't need to be worried about not referring people into memory services. I think we've had that slide, so it's a duplicate. So, consent. You do need to gain consent from the patient before you undertake the tool. And what I tend to suggest is that don't make a blanket assumption that people with dementia don't have any understanding. So I would always explain what the test is for before you do it and what you think is going to happen at the end of it. Actually, that you might diagnose a moderately advanced dementia, and that you're doing it because that will support care planning and give them support. That also needs to be explained to the care home setting. It doesn't need to be some huge drawn-out thing. You just need to explain to people what you're doing. And that if it is positive, that it will be recorded in the records. Care homes and families do worry enormously that by getting a diagnosis of dementia, that mum might end up being moved from their care home. As the majority of people living in care homes will have dementia, a diagnosis by itself won't mean they will have to move settings, but it is a common concern. If you think somebody lacks capacity when you consent them, you need to do a best interest decision and obtain consent from the patient's carer and family members. And we can talk about that in a bit more detail if you need to. But in the same way that we do with any decision making, we're working in the best interest of somebody if they lack capacity. So just going now through the Diadem tool itself. This is what the tool looks like. Here you've got 3 paper versions, an app version, and a System 1 version. We're going to be looking at one of the paper versions using the mini cog, and this is what it looks like. And you'll be given copies of this paper tool and access to be able to print them out when you need them. You can make a diagnosis of dementia with a high degree of certainty if all 5 of the criteria are met. The first criteria is functional impairment. The person is no longer fully independent in relation to basic activities of daily living, washing, dressing, feeding, and attending to their own continence needs. Or there is a requirement for prompting and supervision of staff, which means that they're not fully independent. So that's the first criteria. So somebody who's doing everything for themselves would not, without any prompting or any help from staff, would not fulfill that criteria. The second one is that you would do this thing called the mini-cog. And I wasn't planning on going through in huge detail about how to undertake the tool, but it is fairly self-explanatory. But if people feel that they need more education on the tool, then we can do that separately. And that's the second bit of the tool around clock drawing. To interpret the mini-cog score, you add all the 3 items together and you come up with a score. A score of 0, 1 and 2 means that there's a high likelihood that the person has dementia, and that would be positive. If it's 3, 4 or 5, it means that there's a lower likelihood. And at the moment, what we're going to suggest in this service evaluation, that all the scores and all of the screens are going to be sent to the team so that we can evaluate how often the score comes back as indeterminate or of lower likelihood. You need a good corroborative history. You'll see from this slide that I've put typically for the last few years, but this we've modified in the newer version to 2 years. So what you're going to get from the history from the care home staff, relatives and records is a history of cognitive decline over 2 years. So it's not an acute thing. It hasn't only just happened, but something that you're fairly certain has been going on for quite a while. And if you can't obtain that history, that could suggest it's a delirium, and then you may need further support. So we want a good history of at least 2 years of cognitive decline. Dementia screening tests and investigations are normal. So what we know is that there are some basic blood tests that probably ought to be done, and that these blood tests are normal. And that things like, let's say, thyroid problems have been corrected. There is a list on System 1 that the GPs can do, request for you, that you can print off, which tells you exactly what bloods are required. I can make sure that Sandra knows of these, and we can put these in the final document so that you know exactly what they are. But basically, full blood count, user needs, LFPs, HbA1c, thyroid function, folate, and B12. And they should all be normal. Now, if somebody lacks capacity to have bloods, then you have to make a best interest decision that if you're not going to do them. And we would also suggest in this group of patients that then you're not going to undertake any brain scanning unless you suspected something else was going on. So, for instance, somebody who's had a new cognitive decline following a fall may need to have a scan, so you would not be able to tick this box, and so they would have a negative screen here. You have to be able to say that you don't think blood tests are required, or investigations such as scans. And finally, what we call our exclusion criteria. So you're saying here you do not think a delirium or a depression is going on. So either you don't think that this mood disorder they've got a mood disorder, so they've been depressed recently, or that they've got a new delirium, that the confusion has only happened in the last few weeks. You've got to be fairly confident neither of those two are going on. Those are the 5 criteria for Diadem. So if you can tick that they're functionally impaired, they have a positive mini-cog, they've got a really good history of 2 years of cognitive decline, you don't think they need a brain scan, you don't think they have delirium or depression, then you're meeting all 5 criteria and you can make a confident diagnosis that this person has an advanced dementia when all 5 criteria are met. So before we move on to the questions and answers, at the very bottom of the Diadem tool, you will see what we suggest is that the information back to the GPs, that this is confirming that there's a diagnosis has been made, and that they can confidently add that onto the records, and that they should save the copy of this Diadem tool or a photocopy into the patient's records. And it tells them how to access further information on Diadem and the guidance from commissioners around making a diagnosis. And that is included on the bottom of every Diadem tool, so the GPs can see that. What we're going to move on to next is that we've got one of the district nurses sat this service evaluation has been asked, and we've been asked as a team. So we're going to go through some of those questions, and Sandra introduced questions, and then myself, Dr. Gregor Russell, one of the care home, the care trust and psychiatrist in older age, is going to help with, and who is the service leader, and we'll try and answer 2 slides. And then finally, we're going to tell you in the final 2 slides what the pathway is for this service evaluation and some of the timescales. I'm now going to hand over to Sandra, who is going to ask us some questions, and we hope that if there's any other questions in the future, that we will add them into a future webinar. Thank you.
So how do we ensure people have good access to post-diagnostic services and the diagnosis is not made in isolation?
I think from my point of view as a GP, Sandra, that I think it's really important that once you've made a diagnosis, that it's communicated to the people around. So actually families are aware, and that the care home is aware, and actually that then should trigger the GPs to do yearly dementia care planning reviews, and for the care home to support families. That it's about sharing the information, really. I think they're not going to access the same post-diagnostic support that other people will have in the community because they may be living in the care home. Would there be anything else you'd want to add, Gregor?
Getting the diagnosis will help access any other services that the person may benefit from. So, for example, it may flag up and allow a better understanding of needs that would allow a referral to the care home liaison service, for example. So I think it's the communication with other relevant agencies is the key here, as you said.
What are the responsibilities of the person making the diagnosis, and how do we make this clear?
I think the responsibilities are around that, the consent, following the tool with integrity, and then communicating the diagnosis afterwards. Don't see it as just a tick box, but actually something meaningful. And so it's just about being clear with your communication before, with the consent, and afterwards telling people about the diagnosis. Was there anything else you would want to say to add into that, Gregor?
I mean, I suppose from the purpose of this evaluation, everyone that's seen with the Diadem tool will receive a subsequent follow-up review by one of the old age psychiatry team. So at this stage, the final responsibility for confirming the diagnosis will still lie with the mental health services. Of course, we hope that by showing that the Diadem tool, when used correctly, gets to an accurate result, we hope that won't be needed in future. But at this stage, there'll be a cover from old age psychiatry to review all the assessments that are taking place.
Okay, and as we all offer domiciliary services, what benefits would it bring to diagnose frail elderly people?
This isn't about excluding people or denying them access to care home liaison. For me, this is more about using our services wisely and yes, they could have a visit from care home liaison to make a diagnosis by using Diadem in the future. But actually, if it can be made confidently without that happening, that means that service is better able to support maybe, say, more challenging behaviours or prevention of delirium or education, which might be a better use of those more specialist services. So I think that's why I think Diadem is of a benefit, as well as having domiciliary services as well.
And in the cases where the patient doesn't speak English, would this tool still be the right one to use?
I think, for me, I would say yes, but Gregor, I think you've got some information around Minicog that might help with that question. Do you feel it's still the right tool to use?
Yeah, so there are no robustly validated cognitive tests which would work across all populations and all languages. The reason that we have moved to the Minicog for this version of Diadem is it is the one that probably has the best cross-cultural validity. It's the least affected by language effects. So I think there isn't an ideal test to use, but I think by using the Minicog, we are doing as much as we can to minimize this as a factor. And the other aspects of the Diadem tool, the corroborating clear informant history showing the decline over a substantial period of time of 2 years, and the information around loss of function in activities of daily living, those wouldn't be affected by the cultural background. So yes, I think we can use this tool, but that's one of the things that we will be looking at in the evaluation.
And once the assessment's performed, who's responsible for sharing the information with family, relatives, social care of the diagnosis?
For me, that goes back again to that responsibility to the person making a diagnosis. I think if for Diadem in general, it will be the person signing that form and then adding it on, who then sends it to the GP, so that person who fills in Diadem. For this a service evaluation, I think that would be a joint responsibility. Obviously, the psychiatrist who's doing the service evaluation is going to make an informal diagnosis, but I would still like, once that's done by the psychiatrist, that actually the district nurse who uses the tool in this case is the one that is making sure that they've told the relatives and the care home and the GP. It isn't onerous. If you've already consented them, it's not going to come as a surprise. But I think that good communication is important.
Yeah, so because we're looking at a population who the tool will confirm a diagnosis of severe dementia, then issues around starting cholinesterase inhibitors wouldn't be relevant. NICE wouldn't recommend them to be initiated at that stage of dementia. So medications that we'd be considering would be in the context of behaviours that challenge as part of the dementia. And we'd only really be thinking about starting medications in such circumstances after a proper psychosocial intervention and trying non-pharmacological interventions first. So that would be done through the care home liaison service. So yes, I'd agree that if there were concerns like that, the appropriate channel would be through care home liaison, and that could be accessed by the Diadem process in this evaluation, that the referrals will go through care home liaison to get to the psychiatrist who's doing the review.
So how do we ensure prolonged delirium isn't missed?
Yeah, so I think there was a couple of questions that people have asked around delirium and misdiagnosing it. So I think if you're at all, so delirium does cause perception problems, so people, sort of being sleepy and it being a more sudden onset and being a sudden change characterises delirium. So, and some deliriums can go on for a long time, and that's where really this long history of a cognitive decline over 2 years is really important. So it's really important that that history is followed. And I think if you're at all unsure that maybe something doesn't feel right and that maybe there is a delirium, then this is where, again, you'd ask for extra support, either from the visiting psychiatrist, the psychiatrist who's going to confirm the diagnosis, or the GP team about whether you want to do urine tests and other blood tests and things. So I think if you think that a delirium is going on and it doesn't fulfill that really good history of 2 years, then I think you'd want to involve somebody else. I think we've been asked about whether 2 visits are needed. That somebody's not going to come into any harm by waiting to see what they're like in a few weeks' time if you're at all unsure. But again, it goes back that it should be a fairly long, good history. Would you want to add anything into that, Gregor? Because that's obviously probably the situation that you see people who've been sent to you who've got a delirium rather than dementia.
The time criteria built into Diadem should guard against that, in the sense that if someone has a 2-year history, which is what we're asking for, that is improbable that it's going to be delirium. Delirium is a marker of severe physical illness, and I think it would be very unlikely that it would be persistent for a 2-year period without it being manifestly obvious that there was an underlying physical cause, or indeed at all. I think that it would resolve before that, when it to be delirium. So I think we can be confident that if we're getting the 2-year history, we should be able to exclude delirium using that.
So what do we do if the GP is unwilling to code dementia based on the assessment?
One of the keys, and another question that we've been asked is around evaluations. I'm planning to go and talk about this evaluation project, hopefully maybe with you, Sandra, through the clinical commissioning forums for GPs, so that they'll know what we're doing, how we're doing it, and I'll also write out separately to the practice we're involved in about the project, about the coding, but also the actual code for this evaluation will come from the psychiatrist who confirms the diagnosis, so there shouldn't be any problem with this. And if we do hit problems, we'll learn from that and obviously look at how we communicate with GPs, but I don't have any concerns about that.
In terms of having a negative screen, so if the results from the screen come back and they're 0, 1, 2, 3, or 4, what do we do with those results?
But for this evaluation project, we're planning that all the results are going to be looked at. So the district nursing team at the moment involved in this pilot don't need to worry about the negative screens. As part of this service evaluation project, we'll look at how commonly that happens, what kinds of difficulties people have, and that will form part of the evaluation so that we can then decide whether further research is required. But actually, they don't need to worry about this. All screens will be forwarded on. But again, I'd go back to that big thing at the beginning, which is you are confirming a diagnosis of advanced dementia. So actually, you're only going to do this tool as I'm fairly sure it's going to be positive before I even start, and this is confirming it. But you may find people who unexpectedly then don't score the full 5, but in this evaluation project, we'll still be looking at those people as part of the pathway.
In terms of positive results, and then moving on from that, specifically around dementia, how do we start the conversation about advanced care planning?
So what I would suggest then is this is where I think we need to involve practices and community matrons and look at what other support is going into homes. There is a big training project going on throughout Bradford to train lots of people within care homes, district nurses, social workers, GPs, on advanced care planning techniques that's being rolled out at the moment. And so there will be lots of people who are going to have more knowledge on how to do it. But I would suggest that's one thing that I would want at the moment to involve community matrons and GP practices. If your individual practice district nurses hadn't been involved in much advanced care planning before, because that's the so what bit of this. So what does a diagnosis mean? So actually trying to get support from the practice to sort of start looking at DNA, CPR and advanced care planning and advanced decisions to refuse treatment would be quite important. but I don't think it's only the job of the district nurse who's made this diagnosis, so they don't need to worry about it. They're working as part of a team.
Okay, and another question that comes up a lot is around recording and sharing information about mental capacity.
There are really brilliant tools on System 1 that help us in general practice record a capacity assessment and code all of that. That isn't maybe available at the moment to district nurses from what you and I have talked about in the past, Sandra. So I'm going to make it my mission that that if we have templates that we already have within primary care land of System 1, that those are shared with the care trust, because we have a central sharing area where we can put templates, which means that we can access stuff. So I'll take that away and ask them to have a look at that. You can have access to those templates, which just help you record better when you've done a mental capacity assessment and a best interest decision making.
Absolutely, and maybe in the interim we continue with the processes we have in place at the moment, which is which is access to the consent template via a care plan. And obviously the rules around mental capacity and gaining consent are the same for the current procedures that we use. Absolutely. It's not something to be frightened of, but in the same way that you are always sensitive about getting consent, you just have to remember about a lot of it is about a good conversation with people, families and carers and the person living with dementia before you start railroading through a process. Just have good conversations with people and then record those conversations. Yes, definitely, yes, brilliant. And I think we've answered the other ones now about getting GP practices on board. And lovely.
I'll just add one final comment about the negative screens and to reinforce what you're saying, Sarah, about the fact this is not intended to be a trawl through care homes hunting out people who don't have diagnosis of dementia. That would be beyond the scope of Diadem. What we're looking for the tool to do is to validate a diagnosis that everyone really strongly believes is there already, but that current systems aren't allowing it to be captured and put onto record. So we shouldn't see too many negative screens because really we're doing it in people who everyone knows has got dementia. However, that's one of the things the evaluation will look at. We can see if our impression this will be a relatively unusual occurrence is borne out by reality. So the pathway for using the Diadem tool will be as follows. The title at the top of this slide says following a positive finding, but in fact this is the pathway for all use of the Diadem tool, including negative screens. So once a Diadem tool has been completed, the district nurses should email the Sandra Dunford and also myself, and the email addresses are included in on the slide. So that includes negative screens and positive screens. What we do with the screens once we receive them will vary. The positive screens will be forwarded to Sarah Sheard from the Care Home Liaison Service by Sandra, and Sarah will then do the necessary admin to open the referral and allow BDCFT staff to do the follow-up. She'll then book the person into an assessment slot with one of a team of consultant psychiatrists who've all agreed to help support the evaluation, and they'll see them over the coming weeks and do a focused assessment as to whether they think the dementia diagnosis is supported by the evidence and compare that with the findings of the Diadem tool. They will then send a letter to the GP which will confirm the diagnosis and ask them to add it to the dementia register. And if there's any needs arising out of that assessment which haven't already been picked up, then they can get in touch with the Care Home Liaison Service again and arrange follow-up, for example. Any behaviours that challenge that have been picked up, will be dealt with as a result of the process. Oh, and I should add the negative screens. I will take a look at any negative screens that come through and try to get a feeling of what the cause of the negative screen was. I'll discuss with Chris North from Care and Liaison Service and Sarah Sheard if necessary, and then we can decide on a case-by-case basis how to proceed, whether it looks like it might be perhaps early dementia and whether memory services would be appropriate for this person, because we can do a small number of home visits as part of the memory service, whether Care and Liaison Service, or whether it actually looks more like a medical problem that the GPs need to pick up on, and I'll arrange the necessary follow-up from that. So the plan for how we go forward from here, in January of next year, 2020, which might be this year by the time you're hearing this, we'll be rolling out the training for district nurses on how to use the tool, of which this is part. Sandra can also follow up that with discussions about any points arising within the teams that aren't already covered. Then we hope to go live in February, and we hope at that stage district nurses will start using the tool for this opportunistic detection during existing care home visits. So it will be in contacts that are already planned for other clinical reasons. If you are coming across people and it seems manifestly obvious that they have got dementia while you're in the clinical contact with them, but they don't have the little head icon on the system one saying they've already got a diagnosis, these are the people we're thinking that you'd be using this with. I'll arrange for, we'll try and get 2 slots per week for medical review with one of the old age psychiatry team, and we'll populate those on a rota basis. And we hope to run this evaluation through February, March and April, which will create the capacity for perhaps around 25 to 30 people to be seen with Diadem and evaluated. That will give a reasonable number to a feel for how the process is working. In May, we'd like to, if possible, follow up the use of the tool with some interviews with the district nurses who've been using the process, just to get some initial feel for how that worked and how confident they felt using it, and whether there was any unforeseen things that came out of doing it which we didn't see coming. And then in June, we hope to pull that data together and prepare a report to circulate. And then by July, we'll have the report and we'll be thinking about where we go next. We hope this will create enough evidence to have this as an active pathway within the trust without the old age psychiatry follow-up. And we will also wonder whether we've got evidence for taking it to a wider evaluation. Could this be a process that's used outside of DBCT and the specific circumstances we have here? But of course, we can't jump too far ahead of ourselves. We'll have to see how the pilot goes and what sort of information we're getting from running it. So thank you very much for listening to the webinar, and I hope that's answered the questions you may have. I'll hand back to Sarah now if she's got any final points she wants to make.
Thank you everybody. As always, things like this do raise new questions, and this is a process, not just a one-off. So we're quite happy if you come across questions in the future that we'll add them into future webinars, and we'll try and store up and answer things as we go along. But thank you for listening.